Hi, everyone. Thank you so much, Lisa and Dr. Brown Medical, for this opportunity and Dr. Brown Medical for this opportunity to talk about the late preterm infant and whether those last few weeks of gestation really matter or not. Here are my financial and non-financial disclosures. So I do receive a salary from my place of employment. I am the co-owner for a NICU follow-up treatment program in a clinic here in Arizona. I do receive some financial support for some mentorships that I do and some content I've created for some courses, as well as a presenter stipend here. And then I'm also involved in a few different certification boards and committees across the neonatal therapy space, as well as the pediatric feeding and swallowing space. So those are my financial disclosures that are listed on this slide as well. Here are some of our objectives for today. And really, I'm hoping that through this presentation and by the end of this, we start to understand and add maybe some layers of knowledge to what we have already so that we can advocate for this special demographic and the special population of infants that may or may not end up in the NICU, but still have vulnerabilities and still have needs, some of the medical conditions that might impact them, and then a few ways that we can start to build some collaboration between neonatal therapy teams, as well as teams and on-couplet care, postpartum, mother-baby unit, whatever your specific hospital might call it. I always like to just start with level setting and getting us on the same page, depending on what country you're in. Some of this may be a little variable. So for the purpose of today, how we're going to define our ages and stages is based off of a workshop that was conducted by the National Institute of Child Health and Human Development, NICHD, many years ago. And then the American Academy of Pediatrics, I think in 2007, endorsed this as well. So based on this definition, we are looking at the 34-weeker through 36 and 6, so 36 weeks, 6 days, as the late preterm infant. So from week 0, which is our first day of the last menstrual cycle, all the way through 36 and 6, we consider them preterm infants. And then within that, 34 to 36, 6 is the late preterm. And then from 37 weeks to 38 and 6 is what's called early term. So a lot of times we just call them our term infant, but really they're early term because there's still a lot of development that's happening in utero. And then from 39 weeks to 40 and 6 is truly our term infants, and then post-term after that point. So again, just to ground us, we're going to be talking mainly about that 34 to 36, 6 and spilling over a little bit into that early term infant as well. So just to look again really quickly at just some incidents, what are some numbers that are out there? So at least in the United States, preterm births have been going up pretty steadily. We did have a little bit of it coming down in the 2018, 2019 range, but it's starting to inch its way back up again. And we're still waiting. So typically data is about 1 or 2 years behind. So we're waiting on some of our 2022 data as well. But in 2021, the numbers are in front of you, the preterm birth rate in the United States, at least, was about 10.5%. So 1 in 10 babies still being born pretty early. And from what I can see in the data as well, a big chunk of this is our late preterm infants. And so these numbers are going up also because of that. And while the World Health Organization and the United Nations, the WHO and UN, they do have some guidelines and standardized indicators of how to collect this data, there still is some variability across the globe in how data of late preterm births is actually calculated. And so that's why it is a little bit tricky to get global data. So I stuck with the United States because this is where I reside at this point in time. One of the points, though, is that they did look at the graph that's there in the study, they started to just look more at the singleton preterm births as opposed to multiples, because we do know that when we have multiples, our rate of late preterm deliveries and birth is increased. And so they wanted to look a little bit at just that. And so we are seeing, again, there was a big spike, a big increase. There was a little bit of a plateau, and we're starting to edge up there as well. So just wanted to, again, just put some perspective on this is a growing population that's out there. And so why do we have a lot of these late preterm deliveries? And there are various reasons. So when I looked at the data again, it talks about how about 75% of babies born less than 37 weeks is kind of that range. And the late preterm infants are a big chunk of that. So they are at an increased risk of morbidities involving just about every organ system, and as well as higher risk of mortality. A big part of that is maternal age at conception. So later the maternal age, there are some risks that way, which is maternal health as well. We are seeing that with the increase in maternal age, what the research is showing us is there is quite a bit of an interrelationship between what's called assistive reproductive technology. You might hear it as IVF, in vitro fertilization. And there's also a lot of correlation or interrelationship between maternal age, multiple birth versus, so twins or triplets, for example, versus singleton births, and the interrelationship between the assistive reproductive technology as well. So a lot of interrelationship that way, not necessarily causation, but these variables have been seen to work together pretty closely. There's also been just increase in spontaneous preterm labor, spontaneous rupture of the membranes. And this is actually responsible for about 50 to 75% of late preterm births. So a lot of risk factors there as well. Maternal medical health has been kind of fluctuating, I think also with our pandemic and limited in-person resources. We've seen kind of variability in that. I'm sure we're waiting to see what the data looks like over there as well. And some of these maternal medical conditions can be things like chronic hypertension, gestational diabetes. What is the actual condition of the placenta and the uterus? So depending on what the history of pregnancy has been, the history of conception has been, what does placental health look like, and how does that immediately affect the fetus as well, and then when the baby's born. And then we also have a lot more increased fetal monitoring. We're able to survey things more. We're able to keep track of things early and then deliver early if we see different risk factors like congenital anomalies, anything that's happening with fetal organs, fetal lungs, fetal heart. And so that's another area that is resulting in our increase in our late preterm deliveries. Growth restriction, we're seeing in my unit, we're seeing a lot of growth restriction recently. And then we are seeing just the rate of labor inductions, elective C-sections increasing. The most frequent length of a single-term pregnancy nowadays is about 39 weeks instead of 40 weeks gestation. The mean age of twin deliveries is about 35 weeks and 3 days. So increasing in that predominance of inductions, C-sections, especially for our 34 to 39 weekers. So that's kind of incidence and etiology and kind of where we're at and the why. But let's talk a little bit also about what are some developmental considerations. And this is all still level setting, getting us on the same page, understanding the why for us to also be able to advocate for these infants, for these families, and to be able to speak from a place of understanding as we're building relationships with our nursing and our medical teams as well. And the data is limited and is still emerging. So that's where it becomes a little bit challenging as well to kind of keep watching this area and being able to continue growing in our knowledge base and our advocacy as well. So we often hear this term in your medical areas. Your medical teams might say this, or you might even say this yourself. It's in the literature as well. But we frequently call or refer to our late preterm infants or early term infants as the great pretenders or the great masqueraders, because really they often can fly under the radar or just along the radar and get missed because they act like their term counterparts. They're often large in their size or very comparable in their size to their term counterparts. But their physiological and their metabolic immaturities does place them at risk for a lot of different morbidities, mortalities, complications when we compare them to their term counterparts. And so definitely kind of an area to really keep an eye on because they are very tricky and they're doing just well until they're not. So I know in some units, late preterm infants, if they don't come into the NICU, but they're out on the floor in couplet care in mother baby units. Some places will actually have different ways to color code those infants. So one place I know has different colored hats for those babies. So when a nurse goes in or a practitioner goes in, staff goes in, they know right away just based on the color of that baby's hat that this is a late preterm infant. And so we might have to follow certain other protocols or keep a really close eye on them. Some use colors outside the door. So that might even be a place of collaboration with your teams of, is there a way for us to just even identify for ourselves internally that this is a late preterm infant, and so we might have different protocols to follow so they don't get clumped into their term counterparts that might be doing things very differently. So this is an image that many of you might be familiar with, but I always love using this, and I use this with parents as well. I always have a laminated copy of this on my clipboard when I'm talking to families in the NICU as well as in mother baby unit, because I do see a lot of babies and consults in that area as well. But this is basically a nice image of brain development, and our head can only grow so much, right? We know that. And so the brain continues to grow. In the last 5 to 6 weeks of gestation, our cerebral volume grows significantly, almost doubles in size. And we're creating a lot of these grooves and fat and all of these different essential components, but we're also creating neuronal connections. We're myelinating, we're creating synapses, we're learning about our environment. So there's a lot that's happening in those last 4, 5, 6 weeks of gestation that we may or may not necessarily always stay grounded in because it's happening on the inside. We don't see it happening. And so we have to constantly remind ourselves, remind our colleagues, remind our families that while your baby might look big or look mature like their term counterparts, this is all of the stuff happening on the inside, which is why they're sometimes at risk of some of the other things we'll talk about coming up. So this is, again, just what I've been talking about. There's brain volume growing, but there's also neuronal connections happening. So we know, and we've heard maybe, that neurons that fire together wire together, and neurons that don't won't. So our brain, while it's growing in size and there's stuff happening there, it is also experience dependent. We are learning about the world around us. We've learned certain things in utero, but those are getting reinforced or undone as we experience life outside of the womb, and we start to make a lot of these connections. Our late preterm infants have immature nervous systems. That brain is still growing, that brain is still developing, it's still making connections. And so when they are external, they're outside of the womb, the unnatural environment of our lights, our sounds, our smells, all of the procedures we have to do, even just the birthing process in the labor and delivery OR and then taking them back to mom, even if they don't come to the NICU, can be a pretty stressful experience, even for a term infant, but definitely for our late preterms that are still growing and developing. And then this is often what interrupts their participation successfully in a quality way, as far as feeding, bonding, sleeping, resting, and then ultimately growing. So as providers, everything we do matters. Everything that we do impacts development of our babies and is essentially shaping how their lifetime is to come. So another place to kind of ground us, our sensory system and how it develops. So the first few senses, our tactile, our vestibular, olfactory, gustatory, those and then even auditory to some degree, they tend to develop in utero. And while some of them may be what we call fully developed in utero, they're still learning when they come out how to use those senses and how to master them and how to map that to the world. But I wanted to look at, that's how our womb looks like, and that's where things are growing. But I wanted to look even specifically at our auditory and our visual system, because that's where we're going to see a lot of our late preterm infants and our early preterm infants in that area, right? So even just thinking about hearing and vision, it's still developing. We come out into this world, say it's a 35-weeker, 34-weeker even, but 35-weeker, classic late preterm infant. And now there's alarms in even the delivery room coming back to mom. The lights are bright, there's visitors, maybe the shades are open, the sun is bright, they're getting phototherapy because they have jaundice. There's lots of things going on for this infant that is still growing, their brain is still growing, it's forming connections, they've just come out into the world from a nice, quiet, dark, fluid-filled space, and it's a lights, camera, action right away. So again, we often can forget, or our colleagues can forget, that these babies, even though they look older and look larger and bigger like their term counterparts, are really still faced with the same sensory experiences as our micro preemies, as our early pretermers. And there's still 4 to 6 solid weeks, so we're expecting them to do things that they really are not neurologically ready to quite do. They're not supposed to do this just yet. And similarly, just with oral feeding, I like to just go over kind of these developmental concepts. So again, we're grounded in it. It's not just for the infants that hit the NICU. It is also for infants that don't hit the NICU. All of our babies are developing in the same kind of sequential manner. So a lot of things as far as oral feeding, we start in utero, we start practicing, but we really start mastering, practicing more regularly, practicing within the external context once we're born. And that 34 to 40 weeks, there's a lot happening as far as sucking, swallowing, breathing. So one of the things I often talk about, probably on a daily basis, in my previous hospital and my current hospital when I mentor, is there's something very different about cues. Yes, I'm waking up, I'm arousing, I might try to root, and then I'm rooting and something touches my mouth and I might suck, and that's a reflex. I should be doing that. And there's something very different and more complex when now I have to coordinate swallowing and breathing along with that reflex. So just because the baby is rooting, just because a baby is exhibiting a suck reflex, doesn't mean they're quite ready to do all of the other tasks that feeding and swallowing and just being and breathing and regulating temperature and all of those things require from a neurological standpoint. And this is another piece I feel like it's really good for us to be grounded in, is just fetal lung development. And I'm not going to go through every single stage. There's a lot of literature. There's good resources out there to really learn about this. But what I want to say is our lung development comprises of several stages that are both in utero, inside of the womb, as well as externally once we're born, and beyond the neonatal period as well. So lung development doesn't stop at birth, and lung development doesn't stop at 40 weeks either. So the area I want to kind of focus on is that saccular stage. It's also called the terminal sac stage, and that's between that 24, 28 weeks to about 36 weeks. And there's usually these large clusters of space that's being created. They're called terminal sacs. And this is also where our cells start to differentiate. Surfactant is produced. Surfactant is something that we use in utero in our lungs. Sometimes we give our babies surfactant when they're out in the world to really help expansion of the lungs, to avoid collapse of alveoli. And so all of this stuff is happening, increasing surface area for gas exchange. And you can see in there that is from about 24 weeks to 36 weeks. So if our late preterm infants are born at that 34, 35 week mark, like we looked at our definitions earlier, they're still at that stage of terminal sac or saccular development, and they might have decreased surfactant. And we, again, don't often think about that because that's happening on the inside. And we think, oh, they're past 34 weeks, they're past 32 weeks, they're past 30 weeks, they should be okay. But there's still a lot of development happening. And then the alveolar stage only starts around that 36 weeks. And that is when there's, again, gradual increase in lung volume. That's the greatest surface area for gas exchange. And even that stage doesn't stop at 37 weeks or 38 weeks or 40 weeks. It actually continues all the way up to 8 years of age. So there's a lot of lung maturation that happens along our continuum of life and across adolescence and even as we're growing as adults. And so for the late preterm infant, again, their lung development is at the end of that terminal stage, or the terminal sac or saccular stage. There is a lot of synchrony of that breathing, gas exchange, control that's starting to develop and needs to now grow outside of the womb. There's changes in how they are doing. There's a whole bunch of chemistry and physics I'm not going to go through as far as sodium channels and potassium and length of their gestation, length of labor, all those kinds of things. So the risk of our late preterm infants developing lung disease is actually pretty high because they have some delayed fluid absorption and they have a lot of surfactant insufficiency. And we don't always think about that, again, because we think about surfactant deficiency, but not necessarily insufficiency. So thinking about some of those things as well. And again, just looking at this and just a perspective that are 32 to 35 weeks, right? Those kiddos are within the same stage of lung development, yet we treat our 32-weekers very differently than we treat our 35-weekers. So thinking about some of those perspectives as well, I feel like having this knowledge base and being able to talk to this confidently, for me personally, clinically, has really helped have these really good discussions with my medical team, with my nursing teams of, here are all the things that are happening. How can we actually support these babies? And it's a nice kind of, let's pause and think about that moment. We also, just a point here, and I'll come back to it later as well, are infants of diabetic mothers. So when moms have, whether it's type 1, type 2 diabetes or gestational diabetes, our IDMers, infant of diabetic mothers, have lung development that is approximately 3 to 4 weeks behind, because in the etiology of being an IDM, there is some decreased surfactant, and there's changes in the epithelial cells of the lung structures and all of those things. So those are kids that fall into what's called acquired surfactant deficiency because of the in utero environment. So just something to keep in mind. Our IDM kids, our IDMers, are often in that trap of they're sleepy, they're not waking up, they are eating. And again, we focus a lot on the sugar, which is appropriate, but we also need to focus on what is happening anatomically for them. And physiologically, that's then impacting some of those other pieces of our puzzle. And this was an area for me when I was reading and researching in preparation for this too. It was very interesting for me to see that there's actually some long-term research that's been done, long-term follow-ups for this particular population that I wasn't necessarily quite aware of the degree of it. And there are some significant developmental risk factors. We, again, often focus on our extremely low birth infants, our micropreemies, and not necessarily our late preterm or even our early term infants on what does this look like long-term. So there is higher incidence of cerebral palsy, mental retardation, developmental delays, emotional disturbances, because again, there is quite a bit of that immature nervous system, as well as how they're learning to fire and wire all of those connections. And then there's also been studies comparing the late preterm infant, comparing them to their term infants all the way through kindergarten. And in these studies, they did control for variables like congenital anomalies, syndromes, things like that. And so they looked at a pretty good sample with removing many comorbidities. And these infants, the late pretermers, are at a higher risk of delays, again, at the kindergarten level, a lot of academic difficulties, attention issues, behavior issues, a higher risk of suspension from kindergarten because of these things, and just a lower neurocognitive score as well. So these are infants that are pretty vulnerable. We, again, think that they're very similar to their term counterparts, but they have real risks, real increased risks of adverse developmental outcomes all the way up to 7 years of age. And so even from a follow-up standpoint, these are infants, even if they don't make it into the NICU, where you have maybe a structured follow-up system or a structured way of sending them to outpatient therapies, should be an area that we're continuing to advocate. And maybe that's the first place that you work on if this is where you're trying to build some relationships on your unit, or you're starting to want to get consults in mother-baby unit, and ways to kind of talk through why this is important and why the role of a neonatal therapist is important in that demographic. So let's look at some of these pieces. I created this image because when I think about the late preterm infant, or I think about kind of the sequelae of stuff that happens with them, I always kind of feel like it's this juggling. Like there's the provider, there's maybe us as clinicians, as gatekeepers in the middle, there's the parent and the child, and then there's all these balls kind of around them that are moving, because there's this interplay of lots of different things. So often the late preterm infant is at, usually the biggest risk is that respiratory issue, respiratory distress syndrome, or even just respiratory distress, RDS. It's one of the most common respiratory disorders affecting late preterm infants. And the incidence of RDS decreases from about 10.5% at 34 weeks to 2.8% at 36 weeks. But it's still there, right? And 0.3% at 39 weeks. So from 36 weeks to 39 weeks, there's still quite a bit of a percentage. Yes, it might seem smaller, but there's still quite a bit of risk for that. There's also risk in the respiratory area. There's RDS, but then there's TTN, transient tachypnea of the newborn. There's apnea. There's a lot of basic pieces where their lungs are developing. There's that transition from in utero to ex utero life, surfactant insufficiency. They're, forgetting to breathe because of brain maturation, central nervous system, all of those pieces of the puzzle. And then they have a big piece that the other piece is temperature and how they're regulating their temperature. So the late preterm infant has decreased white fat. They have their hormonal regulation of the brown fat is different. The way the hormones peak at term. So there's a use of prolactin, leptin, norepinephrine, T3, cortisol, lots of different science behind that. But all of those things are very different for our late preterm infants compared to our term infants. They have also just increased body surface area to body weight ratio. So lots of, again, physical, chemical things that are affecting, anatomical things that are affecting temperature for them, that it's really good for us to know. The maturation of their hypothalamus as well is a big part of temperature regulation. So if we have an immature brain, we're going to have an immature hypothalamus, and that's going to affect things as well. And then when we have temperature irregulation, we could have hypothermia, which we're cold. And then we start to have things like hypoglycemia, drop in our sugars, respiratory distress, poor feeding. So it's kind of this ongoing factor. We might have infection. So maternal factors, infant factors, mode of delivery, all of those pieces can impact infection. So these are kids that might be going through what's called a sepsis evaluation, which usually that will buy them a NICU stay, depending on your setting. They have hyperbilirubinemia or jaundice levels. Their bilirubin levels are high. That's often a big part of it. We'll go through that in a little bit. Then they're dehydrating, not keeping enough moisture. So it's this constant like chicken or egg, what's causing what? And then all of this, again, from an oral feeding standpoint, there's immaturity, there's all of these other factors that are happening, that we are constantly looking at this in addition to what is the caregiver going through, what is their emotion, and what's their expectation. They've probably been told, oh, your baby is past 34 weeks or your baby's 35 weeks. They're close to term now. They're just a late pretermer. They should be okay. This is probably not going to buy you a NICU stay. In many NICUs, the cutoff is 35 and under. You get into the NICU. Some places will do 35 weekers as well, are a direct admit to the NICU, but a lot of places are moving away from that. And if you're 35 and 2 or 35 and 3, you might just be out on the floor unless you show us one of these things. So what is that caregiver now expecting? They thought everything was fine and they're not going to be in the NICU. They're not going to have the separation. And all of a sudden, all of these balls are in the air and there's constant juggling happening. And so I kind of put this here. I feel like it's the snowball effect, and one thing impacts the other, impacts the other, impacts the other until you're just rolling and creating this whole avalanche almost. And so, like I said earlier, what's causing what? Did I have respiratory distress and I'm working on my lungs? And so I don't have the endurance now to also suck, swallow, and breathe and eat because I'm barely breathing. And then now I didn't eat very well. So I dropped my sugars. So I have hypoglycemia. I didn't eat very well, so I didn't excrete very well. And so I have hyperbilirubinemia. I have temperature instability. And so I'm working really hard to just keep myself warm. And so I don't have energy to eat, and I'm going to drop my sugars, and then I'm going to dehydrate. So again, there is this constant battle. I feel like kind of what I picture, the snowball falling down and just boom in our face until we really have to make some tough decisions or some quick decisions in order to support these babies. So really thinking about what are all of these things and what's the sequelae and what's impacting the other, and it's never just one thing that they're struggling with. The lower the gestational age of that baby, the more risk for all of these factors. And again, a really nice place for us to come in as neonatal therapists and the neonatal community to really support them. To look at also ways to support these infants, one of the theories I use, it's a big grounding factor for me. It's probably one of the bedrocks of my practice, is the synaptive theory of development. And really this theory of development talks about the intradependence of these different subsystems, as they're called, the concentric circles that you see, and how the infant is really in continuous interaction with the environment that they're in, whether that's in utero or outside of the world. And this is, again, a theory that is often referenced in the NICU, but I actually even use this with my older kids that I'm seeing for like feeding therapy at maybe even 2 or 3 years of age. I talk about this a lot, even as ourselves as adults. If we are not autonomically stable, there's a lot going on, we're in a state of distress, we are struggling to interact with our environment. So this is a theory, again, that can really go across all ages and stages, whether it's the mom, the dad, the grandparent, the baby, but especially for the baby, thinking about what all is going on in their environment in utero as well as externally that is constantly impacting how they're interacting, how their state of being is, and where can we pop in and what can we regulate for them so they have the energy and endurance to be able to do the other things. We know that our babies are not the best multitaskers, so how can we help them through this process? So again, just something to keep in mind. I'm trying to kind of, through this presentation, give you some tools in your toolkit, if you don't already have them, to be able to take this and advocate to your medical teams, to your nursing teams as well. And I don't think any presentation can be complete without leaving you with at least, again, some techniques and tips to be able to use in this environment of the late preterm infant, as well as the early term infant. And really even a term infant could benefit with a lot of these things. And a lot of the strategies I'm going to talk about right now are very second nature often to the NICU setting. We think about it as, oh, that happens in the NICU. That happens for our micropreemies or our low birth weight infants or our itty bitties that are there. But really, these are techniques that support synaptive theories, support state regulation, support our physiological stability across the board. So really changing the trend of this is a NICU thing to this is external. So if you have the opportunity to do presentations or seminars or continuing ed or learning opportunities with your staff in couplet care, in mother baby units, with the nursing staff, these are things that really are tangible things for them to work on. So something as simple as modifying the environment. So typically, if you've been into just a healthy mother baby unit, usually when you walk into the room, the lights are bright, there's a lot of guests, there's visitors, there might be siblings. And again, not that those are necessarily negatives, but how can we protect the environment for this baby that just came out of a nice quiet space, is transitioning to the world, is learning with an immature nervous system and a brain that's still developing? How do I take all of this and code this together? And what is my priority? Do I listen from an auditory standpoint? My hearing has not fully developed, but I have to quickly do that. Or do I wake up and I feed, right? So these are some of the things to talk about, even just, hey, let's keep the volume down. Maybe let's dim the lights. There's also a lot of assumptions that when we make the environment calming, it puts the baby to sleep, and that's why they're not waking up. And so kind of dispelling some of those myths of when we get into this space, if us as adults, if we're go, it's really hard for us to rest and relax and then be able to wake up and perform and go back to work the next day and actually remember what we did and encode that in that brain. So for your baby that's brand new and learning this, let's give them this nice calm environment so they can sleep, they can rest, the brain can grow, they can wake up to have energy to do some of these things and interact with the world in an appropriate way, to learn that this is fun, and then go back to sleep again. So just some different ways that you could present it. And really talking about protecting that sleep and decreasing the sensory input of that. It could literally be turning the TV off, turning the blinds a certain way so the sun is not on them while there's other people there. Or when the baby's sleeping, let's just have them, bond with mom or dad, let's have them skin to skin. When the baby's awake and more ready for participation, then maybe let's hand it off to other people that are visiting that want to, you know, coo and coddle the baby and touch and cuddle and all of those things. Really providing opportunities for skin to skin, whether that's right away in the delivery room or after. Skin to skin is really a proven method to conserve our temperature, to soothe the baby, to help bonding, supports their positioning. The other thing that in the mother baby unit, postpartum units, essentially outside of the NICU, there's a lot of questions about swaddling. And again, that's going to put the baby to sleep. But thinking about swaddling is an extension of the womb. We're giving this baby boundaries. We're helping them regulate. We're helping them organize themselves. If we were home, a lot of babies do get swaddled. And if really the baby is that tired and that exhausted to wake up and eat, and yes, we might unswaddle them and tickle their hair and wake them up. And now we're saying, oh, look, they woke up and we're going to eat. Did they really wake up because they wanted to and they had the endurance and energy to wake up to then do more tasks? Or are they waking up to the stimulation that we're providing, which then takes away from the first part of decreasing their stimulation? So even just talking to parents about, okay, you know, maybe they get a little drowsy and they get cozy with the swaddle, but it's also supporting their posture and their positioning. They're learning where the world is at. They're not just kind of bobbing around like those, you know, those air puppets that like the things that a lot of companies will use for marketing that you blow air into and they're moving around. We want them to really know where their muscles are, where their limbs are, so they can really function well. And so maybe it's just a little burp cloth around them when you're feeding to give that brain information of where are my edges, where's my boundary. I'm not just floating in fluid like I was before. I'm actually out in the world where I have to work with and against gravity. And again, I'm using some words that may or may not be part of your script for parents because you have to meet them where they're at also. So maybe you're not going to say things like for and against gravity with a parent. Maybe you are, depending on where they're at. So really meeting them where they're at also. Holding in a nice contained manner versus, again, just moving around, passing around, very purposeful movements, purposeful vestibular input. So lots of strategies. Again, I'm going through these because I want us to think about them, not just in the NICU, not just for the preemies, but for our late preterms as well. Many mother baby units and couple of cares and postpartum units are starting to do swaddled baths, which is awesome, as opposed to what's called a traditional bath, which is they're open, they're maybe on a warmer, maybe not. They're on, trucks and they're getting wiped and it's fast and furious. But again, we do have some research as early as last year, as early as 2022, where many studies across the world have shown just the impact of swaddled bath versus what's called more routine, conventional, traditional bath. Some of the research is definitely focused on early pretermers and in the NICU, but we can still extrapolate that information. I'm sure all of us love just something that's more nice and spa-like and we're contained. We're not like, it's not cold and now one limb is getting cold while the other one's getting wet and I'm all over the place and I'm going into my Moro reflex, my startle, and I'm just not sure how to deal with all of this. When we have swaddled baths, it also helps our temperature regulation, our state regulation. Going back to all of those slides in the beginning, we are decreasing our physical behavioral stress. If I have better temperature, I'm going to potentially eat better. If I have better temperature, I'm not going to drop maybe my respiratory rate from an apnea standpoint. There's a lot of things related to, again, temperature and state regulation, physical regulation, that snowball effect. If we can catch one and not exacerbate it, not let our baby go into cold stress, for example, we are potentially mitigating a lot of other risks that are out there. So thinking about some of these as well. And from an oral feeding standpoint, I'm not going to go into a lot of detail on these because I know that there are many excellent presentations, even as part of the Dr. Brown webinar list of like all of the different things that have been provided in the past, I'm sure to come, that go into each of these things in much detail. My goal here is really for us to take these things and think about them in the context of our late preterm infants that may or may not, again, visit the NICU, where some of these are more ingrained. So feeder driven, we're kind of trying to pump the milk in because we want to keep the sugars up, but in the process we're dropping it because they're getting stressed out. Poor state regulation, there's often we'll see kind of this upright in a nursery, we're just feeding them. So how can we switch that, bring what we know to increase physiological stability. Sideline feeding, again, once thought about as just something we did with NICUs, is really transitioning even to full-term infants, because it is our biological norm to feed in sideline. When we go to breast, we're designed to feed in sideline. Whether a baby goes to breast or not is a different scenario that we have options for now, but that's how we're designed as a species, is to breastfeed, to go on our side, to regulate our breathing in that way, to be closer to the caregiver, to have flow rates that are slower. We're not just chugging and gulping, going back to, again, maturation of our suck, swallow, breathe, cues versus coordination. And a big chunk of our late preterm infants do get admitted into the NICU because of feeding difficulties, whether that's I need IV fluids because my sugars are dropping, I'm not eating enough, my, again, temperature regulation, weight gain, Billy levels. But if we just made some of these techniques in the transition nursery, if that's what you call it, or out in couplet care, and I've seen this work in units I've worked at, where just with doing some education, providing these techniques, recommending certain nipple flows, certain bottle brands, breastfeeding, we have been able to decrease the consults from the NICU and the admissions to the NICU, because the nurses are now empowered to trial these techniques before sending the child in. And even something as, oh, they're getting apneic with their feedings, they're throwing up all of their feedings. Well, what if we change their position, change their flow? Will they have more gut comfort? Will they have less difficulty breathing, and then hence not have to come to the NICU? And from a breastfeeding standpoint, to go over this as well, this is a big area and a big risk factor, especially with our late preterm infants. And as an IBCLC as well, this is an area that's very dear to me also, but we really have to make sure that we are supporting the late preterm infant very vigilantly. They are at high risk of kind of, again, being that pretender, not like looking like they're feeding. We sometimes will treat them like our term infants, but they're really having a lot of similar difficulties to our early preterm infants that we support maybe in a different way in our NICUs. They're still learning to empty the breast. They're still learning to, how do I suckle? How do I coordinate? My oral musculature is still developing. There might be maternal infant separation because we had to do an admission, we had to give IV fluids, we had to do phototherapy for jaundice levels, but also from a maternal factor, having a preterm delivery, what the maternal health was prior to that, the mode of delivery, all of those can impact lactogenesis, and it can impact maternal milk supply, emerging maternal milk supply, milk coming in, as you might hear it. So those are real things. There are very specific guidelines from the Academy of Breastfeeding Medicine, which has excellent literature to support us on how do we support this specific demographic. What are some structures we should have in place? How do we advocate for this? How do we monitor their weight? And really, again, that constant vigilant observation, not just in the hospital, but when they discharge as well, which takes me to this. Among the newborns, this is what a lot of the literature shows us, and I do see this clinically as well. Newborns that are discharged and after a vaginal delivery, the late preterm infants are 1.5 times more likely than their term counterparts to require subsequent hospital care, and twice as likely to be readmitted in the first 28 days of life. And when I did work at a hospital that had a pediatric unit, we did see a lot of readmissions, usually for feeding difficulties, things like dehydration, hyperbilly, and even just poor weight gain, which all kind of correlate back, that snowball effect, chicken or egg, which came first, usually related to their feeding difficulties. And there was a big study that was done, it's been a little while, so probably due for researching again. But again, just the readmission rates of the late preterm infant compared to the term infant. And 26% of that time, it was related to poor feeding, which, again, other factors, jaundice or dehydration, but they're all interrelated. So which one came first? Did we discharge them with just borderline levels of jaundice? We're like, it's okay, the pediatrician can manage this, and then we're kind of adding to that snowball effect? Or did we discharge them, just enough, just eating enough, sugars are just fine, they're okay, and then, needing the support externally. So just additional data from the American Academy of Pediatrics. There are some published newborn discharge criteria from many years ago, and they did do a clinical report to look at are nurseries and hospitals actually following these recommendations. And unfortunately, what they found, and I hope this is changing, but 40% of vaginally born late preterm infants are discharged before 48 hours of age, even though their recommendation is to keep them longer, at least 72 usually or more. But they are getting discharged early. There's a lot of needing to change over, having beds available, staffing shortages. And so again, these infants really need to be followed closely. And in some places, there is a criteria of how long to observe them, and it is part of the protocol. So as we're just talking about collaboration as well, we have a lot of this knowledge base. Hopefully we've added some nuggets today. And really being able to support this collaboration by advocating for a pediatric or a neonatal therapy team. So when we're split between adults and peds and NICU and all of these things, it's really hard to build collaboration and to be there when we then start to get these orders. So advocating for that, how do we have a dedicated team? What are ways to collaborate? Let's meet with the nursing team. Let's meet with the medical team on, hey, are you at your next staff meeting? Would it be okay for us to just talk about this one thing? Maybe it's swaddle bath, maybe it's sensory processing, right? Of just to give your staff a couple little tidbits regarding the late preterm infant so we can avoid NICU admissions and increased length of stay. That's usually a nice buzzword, decreasing length of stay, decreasing NICU admission. So if we can provide strategies that is going to decrease that, we're usually able to find our foot in the door. And then what is a manageable referral criteria for ourselves, right? So if we're all of a sudden getting a referral on all of these babies, can we meet that demand? And then a huge collaboration can be with the lactation staff on the mother baby unit. So again, often we have excellent lactation staff, in many hospitals. In a lot of places, though, they're mostly experienced with the full term infant and what that full term infant does. And so we have a way to bring the sensory development, synactive theory, other things that support them, suck, swallow, breathe, reflexes, to that puzzle to collaborate. We're not taking away from their business or taking away from what they do, but adding to their repertoire as well can be really a great collaboration. One thing I have found in my practice is I always feel looking to see what the policy is for that hospital. If there's a policy, let's look to see what we're following and what we're not following, and using that as a grounding space of, hey, I noticed that we have this in our policy, and just from my own knowledge base, I'm trying to figure out how do we implement this? And maybe through that discussion, it is apparent that it's not being implemented, and that might be a quality initiative project that you want to collaborate on and build connections with and find that path into that unit. The National Perinatal Association, I have a couple of screenshots for you coming up, is a great resource on different things to look at, different staff trainings to look at, different variables that we should be aware of. So that can be a resource for you as well. Of, hey, I just read this looks great. What are we doing on our unit? Are there ways for us to make changes or move forward? But the biggest thing when you're working across any demographic and any staff collaboration is, how are our recommendations going to impact workflow for that bedside nurse at the end of the day? And so keeping that piece in mind, a lot of times we might go in and say, do this, do this, do this, do this. And then we've just disrupted their entire day, their entire flow, which then sometimes can build more conflict or clashes because, hey, they just came in, for 1 hour, they did this and they left. So how can we work collaboratively, see what's going to impact workflow, and make these small bite-sized changes? So after you watch this today too, you might have 30 things you want to go back and change, but what's the one thing you can do tomorrow? What's one change you can think about making and communicate, collaborate, and create awareness? These are, again, just some of those screenshots I mentioned with the reference on multidisciplinary guidelines specific to the care of the late preterm infant from the NPA. So again, some really great resources. These are, again, multidisciplinary. So it's not just nursing, not just medical. It combines all of the different disciplines as well. And so to kind of wrap us up, the healthy late preterm infant does face a very high risk of developmental delay, school-related problems through the first 5 years of life. So the earlier we can intervene, the better our outcomes can be. Our lung maturation and our lung development does not stop at 34 weeks. That is often where antenatal steroids kind of stops, and that's a cutoff, that 34-week mark, but lung development is still continuing all the way up to 7 or 8 years of age. 50% of our cortical volume, that brain image, is laid in that last 6 weeks of gestation. We have an immature nervous system, a brain that's developing, a brain that's experience dependent, and a late preterm infant that's out in this world having to deal with all of the same external influences as our early pretermers have to as well. And they are just as dependent on the environment and making those connections as well, synaptic theory, of how to actually maintain equilibrium, homeostasis, when all of these things are going on internally for them and externally. So all of the strategies, the neuroprotection that we implement and work so hard at inside of the NICU really can be and should be generalized to our mother-baby units, to couplet care, whatever the terminology might be in your country or your unit for those areas of your hospital. And then really collaborating with the staff there. The neonatal or pediatric therapy teams do play a vital role in this population. So whether that's in your NICU, you're not getting orders for that demographic, or you're trying to expand, or you're trying to build maybe a level 2, level 1 nursery caseload. These are really areas that we can help and we should be helping in order to intervene early and positively impact those long-term outcomes. And I wanted to put this here as our wrap up. I hear this very frequently from some of my medical and nurse colleagues of how they would much rather take care of a 23-weeker versus a 36-weeker. And the big reason for that is because they always tell me the 23-weeker is predictable. I know what they're going to do. The late preterm infant is so unpredictable. They're hiding under that guise of looking and acting older, and everything looks like it's going great until all of a sudden they stop putting on that masquerade, they stop being that pretender. And so really, again, being very focused on how can we truly support these infants and these families in order to optimize their development. So these are just references that are there for you. And thank you again to Dr. Brown, and thank you, Lisa, and thank you all of you for challenging me as well to look more into this population and putting it into a way that hopefully gives you what you need to advocate for these infants and families when you hit your units tomorrow. Thank you.
I think the majority of the questions, Ramya, actually come with, like, how do we get to see these babies? You know, we finally, as therapists, now have some we can have some guidelines about therapists in level 3 NICUs, but how in the world can we get to see these? Do you think, one question said, do you feel it's appropriate to have standard PTOT or speech orders on postpartum units, and how to go about that, but how to get to see these babies, especially if they're not in the NICU?
Yeah, thanks, Lisa, and thank you everyone for engaging as well. I think the answer to that is really also going to come back to capacity, right? And, you know, I was seeing there's one about do we need a standard order set? If your therapy team has the capacity to handle that, where I would say, I guess, at least maybe 37 weeks and under, or depending on your capacity, maybe it's at least 36 weeks. I know maybe the 34 to 36 weeks, those babies you're getting standard orders are on. There are a lot of those. We talked about the increasing number of those. So are you as a team able to really meet that demand? Because a big part of building trust is being available. And if nurses or doctors are putting orders in and we're not able to see them or even respond to them, at some point it's going to drop, because why would I put an order in? And also there's an understanding sometimes, which might be part of dispelling myths, is just because an order is in may not need to hold up discharge if that baby's not seen, if they're doing well enough. So I would say those are pieces to really consider as a team. I find that just like historically in many NICUs, and maybe even actually some NICUs right now have said this, where it's a consult model, where or a problem-based model. So, Usually if it's a baby with craniofacial anomalies, maybe that didn't go to the NICU or is in couplet care, there's more chances of getting orders on those ones. Or for our motor colleagues, it might be our shoulder dystocia kids that get those consults. But starting to, I think, do the education of here are some other areas that we can also help in, even if it's staff education. It may not need to be family education. The other thing I find that comes up a lot is this going to create a financial burden for the family? There's misunderstandings or lack of understanding often of how therapy builds and whether that family is going to get a bill at the end of the day because they consulted us. So that would be another area that I didn't mention in the presentation, but might be another place to clarify and build connections and confidence of just because we're coming in doesn't mean it's going to cost more. So I would say those are probably some good groundwork pieces to work out before you're jumping in and offering all of the services, but really starting with communication, collaboration. If I often find that when there's like a personal experience, that usually hits home too. So if it happens to be you have a staff member that had a late preterm, or you had a late preterm, or talking about some of those things down the road, sometimes that can help as well. But we don't all necessarily have the luxury of having to share that story. So I would say just start with communication, talk about what we can bring. What are some things, even if it's that long slide, I feel like that's always been an aha moment of discussion of really, oh, we never thought about the fact that their lungs weren't developed. And starting with one thing at a time, giving them empowering your nursing staff to be able to trial some things and make those changes first is a huge piece of that puzzle. And when they know the why, they can help advocate for you as well, versus just telling them what to do. So I hope that answered, Lisa, the question.
Great answer. And you answered like several questions that I had. The one piece is that now that we brought up that lung development picture, people want to know, it will be in the handouts, you all get that. But if you happen to know off the top of your head, I'm going to wrap up with some other business things, Ramya. If you want to if you have the link to the website or the article, if you know that off the top of your head, if you can type that in. Otherwise, I promise y'all will be able to see it afterwards in the PowerPoints, because I agree. I think that picture is key. I love it. And I told Rami I had never actually seen that before, so I love it. All right. I think that's all we have time for. I want to respect everybody's time. Remember, within 24 hours, you will get an email that talks about how to get your CUs if you've been on for the majority of the time. Right now, what I want to do is, since we're done with this part of the webinar, I just wanted to mention a little bit about the Dr. Brown's Medical Infant-Driven Feeding Program. So when people think about IDF, they often think early preterms and preterms. And while a lot of the scoring, some of the scoring specifics are related to our preterms born less than 34 weeks, you know, Ramya talks about synaptive theory, immature nervous systems, brain still growing, sensory development, protecting the environment. These are all things we do with our late preterms. This is all part of IDF. So the educational component in a lot of IDF really is so applicable towards late preterms, early terms, any baby after all, because let's face it, all babies deserve feedings that are safe, functional, nurturing, and developmentally and individually appropriate, not just preterms, all babies. So if you have any questions about the infant-driven feeding program, please feel free to contact us at medinfo or idfninfo@drbrownsmedical.com. And we can't wait to see you all. If you are going to any conferences coming up, we are going to NANT. We're going to several nursing conferences also this summer. So make sure you stop by our booth and say hi to us. And then you'll get a notice in the next couple of months about our next webinar, which is going to be in July. So as always, we love seeing you all. And we thank you, Ramya, for being here. So everybody have a great day. Thank you and bye-bye.